Hello, my name is George Garas. I'm the chairman of the Integrate Head and Neck Subspecialty Committee. And on behalf of our committee and also of Integrate, the UK ENT Training Research Network, and all collaborators involved in this study, I'll present to you our UK National Audit of Head and Neck Cancer Post-Treatment Surveillance. So if we look briefly at the background, in 2016, the latest edition of the National Multidisciplinary Guidelines for Head and Neck Cancer in the UK were published. And within these guidelines, there is a specific paper relating to follow-up after treatment for head and neck cancer. A number of recommendations were made in this paper, which represents the standards against which we audited. Now, when it comes to the study design, the audit component was a two-cycle audit in order to close the audit loop. The first cycle was retrospective and lasted 2 weeks in 2017, and the second one was a prospective 4-week cycle in 2018. In addition, we also evaluated recurrence patterns, and I'll present you those findings too. Now, if we look at the data set, we had data from 5,123 patient consultations from across all 4 countries of the United Kingdom, from 89 hospitals. In terms of patient demographics, all adult patients were included. The range was between 18 and 99 years old, and the male-to-female ratio was 3:1. In terms of the primary tumor site, just to clarify, thyroid cancer and cutaneous malignancies of the head and neck were excluded. The commonest site was oropharynx, and the majority of those tumors were HPV positive, followed by larynx, with the commonest subsite within it being the glottis. And you can see here the various sites and subsites of primary tumor sites in our patient cohort. So, if we look at our results, firstly, in terms of adherence to recommendations, when it comes to the frequency and duration of follow-up, this was closely aligned to the recommendations. However, when it comes to multidisciplinary clinic input, as you know, the recommendations state that patients should be seen in dedicated multidisciplinary head and neck oncology clinics where a variety of allied health professionals are available. But same visit input from allied health professionals was present in less than 1 in 4 consultations, as you can see from this table. And you can also see the different types of allied health professionals that were available. Most commonly being specialists, head and neck cancer nurses, followed by speech and language therapists, and then dietitians. The next area to look at relates to the imaging for suspected recurrence or residual disease. And the recommendations clearly state that when recurrence is suspected, the recommended modalities are PET-CT and MRI. However, if you looked at the national practice, MRI was performed in less than 1/3 of cases, and PET-CT in less than 1/5 of cases, with the 2 modalities combined in less than 3% of cases of suspected recurrence. The next area to look at is patient support education. Again, the recommendations are clear, and we are all very familiar with how important it is to educate patients with regards to what they should be looking for that may signify a recurrence so that they can expect their appointment, and similarly, how important it is to support them with tobacco and alcohol cessation services. What we found was that in terms of red flag syndrome education, this was documented in 20.4% of consultations. When we came to smoking and alcohol cessation interventions, these were 6.2% and 5.3% of consultations respectively. This, of course, represents an area where a significant improvement is required, particularly since, as we showed, about over 10% of patients continued to smoke at the time of their follow-up, and over 1/4 continued to consume alcohol. This is following their completion of treatment of their head and neck cancer. So this represents an area in need of improvement. If we now look at detection of recurrent or residual disease, in the cohort, 380 patients were considered to have possible recurrence, which was 7.4% of the entire cohort. Of those following the relevant investigations, 119 confirmed cases were present. What we looked at is how routine and expected follow-up compared in terms of picking up recurrence. And what we found was that the rates of recurrence were 35% in expected appointments versus 5.2% in planned follow-up. This is a very important finding that was both statistically significant, but of course also very clinically significant. Of those expected appointments, what we showed was that 2/3 of them were initiated by patients and the other third by the clinicians. And finally, recurrence was higher in those patients that had developed new symptoms. And you can see the specific percentages in the slide. So in view of the importance of those findings, we further looked into that by trying to determine which new symptoms constitute the most reliable predictors of recurrence. And we did that by measuring their positive predictive value for recurrence. So new dyspnea had the highest PPV of 16.2%, followed by new tiredness, 12.9%, and pain, which was around 10%, depending on the specific site where the patient complained this new pain was present. And you can see also the other different symptoms and their respective positive predictive values. So before we conclude, it's important to mention the strengths and limitations of this study. The strengths relate primarily to the large sample size. This study had over 5,000 patient consultation data from across the whole of the UK. And also very importantly, we conducted the analysis at the individual patient level as opposed to using aggregate data. And all this makes the findings very robust. There are, of course, limitations. The main limitation relates to the fact that this was a snapshot study that only looked at 6 weeks of practice at national level. And also no comparisons were made in terms of geographical cancer networks, although that was not the aim of the study. So if we look now at important conclusions, this study identified aspects of head and neck cancer surveillance that may require further improvement in the UK. In particular, further efforts should be made to support greater provision of allied health professionals in dedicated multidisciplinary clinics, and also to ensure the availability of appropriate imaging to investigate suspected recurrence. Finally, the findings also provide a rationale for considering alternative post-treatment surveillance models that will empower patients to take greater control of their follow-up. Before closing, I would like to present to you, if you're interested for some further reading, this is the full paper that you can read, and also a second systematic review that we published that discusses the vital importance of allied health professionals in the head and neck cancer surveillance. Before closing, I would like to once more acknowledge and thank all collaborators that were vital for this study to materialize, which you can see in the next slide, and also are on the paper. And my special thanks to those individuals below, and to the entire Integrate family, as well as our head and neck subspecialty committee. Thank you very much.